Looking at me, so I assume that's a question for me.
And several people can weigh in on the same question.
Yes, some people are carriers of staph.
Will you repeat the question?
Oh, I'm sorry. The
okay.
question had to do with whether some people were carriers of staph aureus and therefore predisposed to getting infections with that particular organism. And the answer is yes. A certain percentage of us in the room carry staph aureus at various sites. The most common site of carriage is in the nose, in the anterior nares, but it may be on other skin surfaces. And that's true for not just MRSA, but staph aureus in general. And so, if we just talk about staph aureus, that's a genus and species of bacteria. Some of those are resistant to methicillin, and some are susceptible. The ones that are resistant, we say, are methicillin-resistant staph aureus, MRSA. On average, if we, again, were to get culture specimens from everybody's nose in the room, as gross as it sounds, probably 25 or 30% of us would have staph aureus in our nose. Most would not have MRSA. But when we carry it on our skin, and then we get a little nick in our skin, maybe from shaving or maybe from just bumping into the table, or just common everyday occurrences, just that little bit of trauma can push the staph aureus through our skin surface, and then we can get a boil from it. And sometimes
what usually would show up would be like a blister or a boil?
Yes. The skin and soft tissue infections that we see due to MRSA mainly come in the form of, again, we have a medical term for boils. We call them furuncles, so it's furunculosis. We can't just say boils. And then again, if you're a chronic carrier, you can get that repeatedly.
And is there any way to test for that? Is there any way to prevent getting recurrent infections?
So the follow-up question had to do with testing for it and preventing subsequent infections. Yes, there is a way to test for it, and we can do that in a number of ways. Again, we can just get a swab specimen from somebody's nose and just send it down to the microbiology lab and see if it grows on a culture plate, or we can do a molecular test called PCR, polymerase chain reaction, to see if somebody has it in their nose. The issue with doing that, though, for everybody is that most people who are carriers don't have infections. So what you end up with is just sort of a large group of people, but only a small fraction are chronic carriers, and only a fraction of those people actually get clinical infections with it. So for most of us, it doesn't cause us any problems. But if you were going to, say, go in for surgery, say an elective surgery, it's starting to appear as though knowing about colonization ahead of time and maybe attempting to remove the organism through topical treatment would then prevent subsequent post-surgical infection. So there is some of that, but those are specific patient subsets. We would not do it for an otherwise healthy person who was not having surgery.
Had an infection that was cultured and diagnosed, treated with antibiotics. 2 or 3 weeks later, they developed more infection once they completed their antibiotics. Would that be the kind of person that might benefit from further testing?
So the question has to do with what about the person who has an infection, it gets treated and it goes away, and then they get another one. What to do with those people? Yes, they get sent to our clinic a lot of times, and we're asked that exact question. The problem is we don't have a lot of data on whether or not our interventions to decolonize somebody actually works. We try different things. We can give an antibiotic ointment that the person literally puts in their nose, or we have them bathe with a special kind of soap, or just sort of common sense sorts of things. And sometimes it seems to work and sometimes it doesn't work. What happens for most people, though, is over time, and it may be months to even years, they will eventually rid themselves of the bacteria. But in the meantime, oftentimes they have a very difficult go of it, and we basically end up treating episodes of infection. You get one, we treat it the next time.
Routine antibiotics.
So the question was, do we put people on routine antibiotics, like they just take an antibiotic pill all the time? No, we try not to do that.